to start with, dear friends, do you know what high altitude can cause to our eyes? Probably no. I mean exactly what it can cause. So before starting, let me take through the journey what it can cause to our eyes. So this is a central retinal artery occlusion in the young adult, where there is almost 100% occlusion of the carotid artery and he is blind from one eye. This is again one of the young 30 years old male patient who has developed again occlusion of the 100% occlusion of the central retinal artery, carotid artery, and has developed the ocular ischemia. This young patient has got the branch retinal vein occlusion. Here, these young patients, they have got the central retinal vein occlusions, branch retinal artery occlusions, and CRO, CSCR, and these are the hemorrhages in high altitude which can mimic this anemic retinopathy, leukemic retinopathy, where we can see the white-centered hemorrhages also, and these are the high altitude retinopathy with the different grades. It can mimic the hypertensive retinopathy, lupus retinopathy, and disc edema. So to start with, the high altitude retinopathy is defined as a retinal abnormalities caused by prolonged exposure to hypoxic environments, primarily occurs at high altitudes above 11,000 feet. Now, what is known in the literature is that rapid ascent to the high altitude can cause the high altitude retinal hemorrhages and various complications like CRVO, BRVO, etc. But what is not known is that if you are well acclimatized and then go to high altitude, then also it can cause number of complications in your eyes. So this study was undertaken to fill this research. So it was an observational cross study where 1457 security personnel were there, age ranging from 20 to 54 years, and they were stationed at altitude more than 11,000 feet. The baseline ophthalmic examination was carried out, standard acclimatization schedule was defined by the central body was conducted, and on the last day of acclimatization, again the ocular examination was done, and all these patients had spent a minimum of 3 months at high altitude more than 11,000 feet. So these were the exclusion criteria, and so coming to the results, the mean age was 34 plus minus 2 years, and there were out of 1457, 12 patients were diagnosed to have the high altitude retinal hemorrhages, and out of these 12 patients, 4 patients developed the foveal involvement, and all these patients were at a high altitude of more than 14,000 feet. So this is a descriptive clinical profile of the fundus findings, where the venous dilatation, retinal hemorrhages, rod spots, vitreous hemorrhage, cotton wool spots, and subretinal hemorrhage and macular involvement were seen in this number of patients. So the high altitude retinopathy, the grade 1 was seen in 3 patients out of 12, grade 2 in 2 patients, grade 3 in 2 patients, grade 4 in 5 patients, and total out of the 12 total patients. Now what is this grading? So you see, if we see, there is a grading which was given by Wiedemann and Tebing in the year 99. And to our surprise, after the year 99 till now, we don't see even a single classification which has been revised and has been given. So this is a grading where we see the mild dilated retinal vein and veins in all the patients, along with the hemorrhages criteria 1, 2, 3, or more than that. So this is a patient, one of our patients, where this is grade 1 high altitude retinopathy, where we can see the hemorrhages up to the 1 disc area, and this is grade 3, where we can see the multiple hemorrhages up to 3 disc areas, and also we can see the white-centered hemorrhages. This is the grade 1. So the statistical significant findings were high altitude risk at significant association between higher altitudes and the increased high altitude retinopathy incidence was seen. And the novelty of our research lies in highlighting the impact of chronic hypoxia on ocular health, suggesting that delayed HARH is an indicator of prolonged hypoxic exposure and potential reperfusion injury rather than immediate hypoxic change. And the expression of thyroxine integrated proteins lead to reactive oxygen species, which leads to the increased oxidative stress. So our study revealed that individuals with lower oxygen saturation and experienced more extensive retinal bleedings, and these were the study limitations. And the take-home message was that delayed high-altitude retinal hemorrhages occurs even in well-acclimatized individuals at high altitude, and the prevalence is low, but potential for severe visual impairment exists. And the regular ophthalmic monitoring is essential for those exposed to high altitudes, particularly above 4,267 meters. Thank you so much.
Clarify 2 points. First, is it related to hypoxia or some change of intraocular pressure?
Related to hypobaric hypoxia. Hypobaric hypoxia.
So it is for people who go suddenly to an higher altitude, or those, for example, in army is staying in Ladakh or some CHN or something.
Yeah. So
what message should they take from the?
Sir, the main study is to fill this gap only, which you are asking. If there is a rapid ascent to the high altitude, we all know that there are so many complications which can take place. So this study is for those individuals who are well acclimatized, going slowly and slowly to the high altitude and staying over there. So despite of that also, on prolonged exposure, high altitude retinal hemorrhages can take place.
What is the basic pathophysiology?
The basic pathophysiology is there is a thyroidine integrin proteins which are released. So these lead to the this ROS is increased, and which leads to the oxidative stress. So this is the accumulative stress which leads to damage to the endothelium and leads to these hemorrhages.
In all such cases, you go for serious workup. In all the cases.
Pardon me?
Cardiovascular workups are done or not in such cases?
Yeah, ma'am, this is a first study of its kind. Only one study has been done prior to this in the literature. So the workup is that's what we are recommending, that regular follow-up needs to be done in those patients even who are well acclimatized.
It's a running of sort for some people.
Yes,
I told you is in CHN or somebody. They should be regularly screened.
Yes.
What inspired you to do this study?
Ma'am, I was posted in Srinagar previously, 92 base hospital, and now posted in Kolkata. So number of cases serving soldiers who are coming from the high altitude, they were coming with the ocular ischemic syndrome, central retinal occlusion, and hemorrhages which can mimic the lupus, like leukemia, sometimes this anemic retinopathy, etc. So there's number of differential diagnoses, and at the end of it, it turns out to be high altitude retinopathy. So these are the entities which everybody should know, I think, and there's very less known in the literature.
Does it really differ from other kind of toxic retinopathies we encounter every other?
No, it's same, but hypoxic retinopathies are mainly in the high altitude only we see.
Otherwise also we see, but it's not much that it has to be audited.
For example, in patient SpO2 level is falling.
SpO2 is falling.
For example, in COVID, they can also have an
Yeah.
Deficiency in ears also as well.
Yes, ma'am. Yeah, that's what I'm saying, ma'am. It's like similar to anemic retinopathy. So those it mimics those only. But then the difference is, you will see that hemoglobin is fine, but it mimics the anemic retinopathy.
Nice presentation.
Thank you so much. Thank you.
Dr. Divya, just put the mic closer to you.
A hospital-based comparative study. There is no financial support. CKD is defined as kidney damage or GFR less than 60 ml per minute per 1.73 meters square for 3 months or more. The reason for cataract, subconjunctival calcification, retinal abnormalities may be due to etiologies leading to CKD. Retinopathy in CKD is frequently asymptomatic and is a potentially reversible cause of vision impairment. The primary aim is to compare the occurrence and severity of retinal changes in patients with CKD and patients with diabetes and hypertension without retinal disease. And the secondary aim is to assess the prevalence and pattern of retinal abnormalities and to identify the factors associated for the development of these retinal abnormalities in CKD patients. It is a cross-sectional study. Group 1 contains patients with CKD and Group 2 contains age and gender matched patients of diabetes and hypertension without renal disease. After taking informed consent, detailed history was recorded, and in group 1, duration of CKD and lab tests were recorded. In group 2, lab tests such as HbA1c, FDS and PPPS, serum urea creatinine were recorded. All patients underwent comprehensive ophthalmic examination including OCT. All patients above 18 years were included. Coming to the result, here we can see demographic profile. Between two groups, we can see that the age and gender are not statistically significant. That means both the groups are comparable. Here in this table, we can see types and prevalence of retinopathy in group 1 versus group 2. Here total patients with retinal changes are more in group 1 as compared to group 2. Here in this table, we can see OCT changes in group 1 versus group 2. In group 1, there is statistically significant thinning in superior, inferior, average and GCL layers as compared to group 2. Here in this slide, we can see that age and duration of CKD are not associated with retinal changes in CKD patients, whereas stage of CKD is statistically significantly associated with retinal changes. And patients requiring dialysis have more retinal changes as compared to patients not requiring dialysis. Here we can see duration of CKD is not associated with thinning in RNFL and GCL, whereas the stage of CKD is significantly associated with thinning of RNFL and GCL layers. In the current study, both GCL and peripapillary RNFL were found to be significantly thinner in all quadrants except nasal and temporal in patients with CKD when compared to the control group. Factors such as stage of CKD and requirement of hemodialysis are found to be associated significantly with the occurrence of retinal abnormalities in patients with CKD. Stage of CKD was also found to be significantly associated with OCT changes in these patients. All our findings are in accordance with the results of studies reported previously. Here we can see few studies. A comparative cross-sectional study done by Jung Young Chow et al. He noted that non-diabetic CKD patients have thin RNFL thickness in all quadrants except temporal quadrant. A similar study conducted by Sabkal et al. He found that 111 eyes out of 168 eyes have posterior segment abnormalities. So to conclude, retinal abnormalities are common and threaten vision in patients with CKD. The risk increases further in disease with stage 3 and above. Early recognition, monitoring and intervention will result in a better visual outcome for these patients. These are the differences. Thank you.
You have your photographs, fundus photographs.
I didn't record any fundus.
Because you have taken patients of CKD more than stage 3 without dialysis, isn't it?
No sir.
They haven't undergone dialysis.
I have taken
See,
all
CKD
CKD
itself,
patients. I have taken all CKD patients and I have recorded the history of dialysis in those patients.
Because see, dialysis also has a great bearing on the retinopathy.
Yes sir, I have included that table also sir. Patients requiring dialysis have more retinal changes as compared to patients not
Diabetes
requiring
and
dialysis.
hypertension will compound to it, it will aggravate it. You don't have photographs.
Photographs I have not recorded.
You can take a smart
So have you
photograph.
compared the changes, these thickness changes in the patients who are on dialysis and those who are not on dialysis?
We have not made a
Because
comparison
hemodialysis
table, ma'am. I have
itself
taken,
causes ischemic changes in the retina.
yes sir. I have not made a statistical analysis for that ma'am.
So, very nice presentation of paper. Can you tell me one point that, one additional information that you got from your paper, from your research as compared to the previous studies that were published on the same?
We have similar result on this.
So nothing, no new information that we derive from it.
No.
Thank you.
Good morning, sir. My study is based on the association of serum vitamin D levels with the clinical spectrum of central serous choroidenopathy patients, especially of Indian origin. Basic introduction about central serous choroidenopathy, as the name suggests, that it's a subfoveal serous retinal detachment which separates the neurosensory retinal detachment from the underlying retinal pigment epithelium, which generally affects the typically patients of young to middle-aged patients ranging from 30 to 50 years old. The three types of CSR can be categorized depending upon the duration and the symptoms. It can be acute, it can be recurrent, or it can be a chronic patient. Generally, these patients affected are type A personality patients who are more anxious, ambitious, and who are having a higher level of stress in their daily life. Two types of theories are based on the central serous choroiditinopathy, although the exact pathophysiology is not very clear. One is the retinal pigment epithelium dysfunction theory, and second is the choroidal vascular hyperpermeability. The purpose of this study is to assess the level of serum levels of vitamin D in different clinical profiles of CSCR patients, especially of the Indian origin, because serum vitamin D is an essential hormone which is responsible for the growth, development, and healthy skeletal structures, and even regulates the calcium and the phosphorus metabolism in the body. Although no previous study has been done in the literature till date, the effects of the vitamin D has been elucidated in many ophthalmological diseases such as ocular inflammation, ocular angiogenesis, glaucoma, and diabetic eye diseases. We did a case-controlled cross-sectional observational study in which the clinical spectrum, angiographic status of the patient, and OCT-based tomography studies were done. We included patients of all the three variants of CSCR, that were acute, recurrent, and chronic variety. Acute is that CSCR which is a localized neurosensory retinal detachment with the symptoms lasting less than 3 months, although recurrent can be classified as a new episode of CSCR following a previously completely resolved episode of CSCR. And a chronic serous retinal detachment is one that presents for more than 6 months or longer after the onset of symptoms. We excluded all the patients who were suffering from celiac disease, chronic liver diseases, advanced stages of chronic kidney diseases, and patients who were on vitamin D replacement therapy and autoimmune diseases. We had two groups, one is a study group, another is a control group. We did fasting blood levels of serum 25-hydroxyvitamin D levels using the alpha, that is the enzyme-linked fluorescent assay, which a biochemistry analyzer by Vidas. We categorize the patient of serum fasting blood levels. If they are more than 30 nanograms per ml, they are categorized as normal. It is insufficient, it lies between 20 to 30. And if it is less than 20, we call it as deficiency of vitamin D. We did a man-Whitney U test and a Z test with considering the p-value of less than 0.05. We had a results of two groups. 42 CSR patients were considered and versus the healthy group where 44 patients were considered. Although the gender discrimination was not much, the ratio was 37, almost same in both the groups. With male to female ratio, the average of 33 years of age was average in both the groups. We found that the 25-hydroxyvitamin D levels in patient group was almost half, that was 16.5 versus the control group that was 34, almost double. The Bosch viscous chart showed that the serum vitamin D level of the patient group was almost 16 versus the control group where the serum vitamin D levels were 34. The results were that all the variants of CSCR, the acute, chronic, and recurrent, out of 42 patients, 33 patients had low serum vitamin D levels, and maximum vitamin D level was found low in acute CSCR patients versus the normal group where only one patient had an abnormal low vitamin D levels. So total of out of 42 patients, only 2 patients had low levels of serum vitamin D. The discussion is that the lower levels of serum vitamin D levels were present in patients of CSCR when compared to healthy individuals, and this level of serum vitamin D level was found low in all the three variants, whereas the maximum majority of low serum vitamin D levels was found in acute CSCR patients. The discussion is that the abnormal permeability in the inner choroid happens, which causes the stasis, the ischemia, and the inflammation, and the vitamin D deficiency can lead to disruption of the retinal microvascular circulation. The strength of the study is that the large number of eyes were enrolled in each group, and we did specifically the population was Indian population where there is high chances of CSCR. But the limitation was that the vitamin D level measurements were carried out in the serum. We didn't measure it in the aqueous vitreous or the retinal tissue. The conclusion is that the reduction in antioxidant capacity leading oxidative stress and vascular changes that are commonly seen in vitamin deficiency could have a significant role in the pathophysiology of the CSCR diseases. Thank you, sir.
Nice presentation.
Thank you. Signa, very nice. The chairperson, would you like to make any remarks?
What was your age group?
Sir, age group was 20 to
Because
50 years.
generally
Sir. Age group is 33 years, sir, in both the groups, patient group as well as the control group.
Because generally CSCR we see in the young population, vitamin deficiency we see in ladies and slightly elderly population as a normal. Now we attribute vitamin D to any pathology. Are there other studies to collaborate it?
No, sir. There are other studies, but no specific study has been done which specifically signifies that there is low serum vitamin D levels in CSCR patients specifically.
What if the patient is having diabetic retinopathy along with this?
That we have not included, and that was not in the inclusion criteria of the study.
You excluded.
Yes.
What are the various biases of this study?
Ma'am, firstly, we have not measured the serum vitamin D levels in the aqueous. We have not measured it in the vitreous. Secondly, if the patient have been on any replacement therapy, that we couldn't comment on. Secondly, a large sample size can be done, and specifically we are concluding it only on the Indian origin patient. We are not concluding it on a worldwide nation. That whether CSR is affected in all the patients of all the three variants or not.
Very good, Dr. Singh. I really like this novel idea. So for a pilot study, I think it was decently powered. Especially since we don't have any background data on it. So I think this is a good way to start with serum levels and then perhaps move on to aqueous if you think. Now, one question that I had was that how over what period was the
It was
patients
1 year
like-
period.
For a 1 year period. So I'm sure that these patients are treated as well. So when they asked, did you monitor whether with correction of vitamin D levels, was there any change or any
No, sir. We didn't do that, sir.
Okay. So perhaps in case if
That was the exclusion criteria, sir. We have not given patients on replacement therapy of vitamin D. If we would have given, then there would have been
there's
changes.
no harm because if your levels are low anyways, it will help you.
It's a very important thing Sir has pointed out. But it should be in the literature as vitamin D as a therapy for CSCR, but no one is using it. There is some contradiction.
Maybe you can come back with more data also. This is good. Thank
We'll
you.
discuss the same with my mentor, sir.
Good.
Thank you, sir.
We'll start.
Yes, sir, please.
Good morning everyone. I am here to present on the topic clinical profile of patients presenting with retinal vein occlusion and its correlation with serum homocysteine levels. There is no financial support or sponsorship. Retinal vein occlusion is second most common primary retinal vascular disorder following diabetic retinopathy. Its prevalence varies from 0.7 to 1.6%. There are two types of retinal vein occlusions, branch retinal vein occlusion and central retinal vein occlusion. Central vein occlusion is the occlusion of main retinal vein posterior to the lamina cribrosa of the optic nerve and is typically caused by thrombosis. CRVO is further divided into non-ischemic and ischemic. In non-ischemic, it accounts for about 70% of the cases and the vision is usually better than 20/200. The central retinal vein occlusion is major cause of visual impairment and blindness, elevated total homocysteine levels, which is associated with venous thrombosis and cardiovascular diseases. That has been suggested as a major important potential modifiable risk factor for atherosclerosis. Similarly, several studies have demonstrated elevated homocysteine levels as potential risk factor in CRVO. The primary objective is to assess clinical profile of patients presenting with retinal vein occlusion. Secondary objective is to assess the incidence of raised homocysteine levels in retinal vein occlusion patients and its correlation with presenting visual acuity and central retinal thickness. It's a hospital-based cross-sectional study. The inclusion criteria includes the patients aged more than 18 years of age and who are diagnosed with retinal vein occlusion. And the exclusion criteria, we have excluded the retinal pathology patients like diabetic retinopathy, retinal vasculitis, anemia, and leukemic retinopathy, etc. Detailed history of the patients was taken, and baseline blood investigations are done, and comprehensive ocular examination is done, including OCT. And this is the statistical analysis. The mean age group of the patients is 55.90 plus or minus 11.54. And the central retinal venous occlusion patients, they fall under 28% of the patients. And branch retinal vein occlusion, the quadrantic are 60%, macular RVO are 6%, and hemiretinal vein occlusion are 6%. 84% of the patients have come with complaints of diminution of vision, and we have seen 60% of the patients having macular edema. When comparison of the central macular thickness of patients with normal homocysteine versus raised homocysteine level is done, it has shown a non-significant result. And when we have compared the best corrected visual acuity in patients with normal homocysteine levels versus the raised homocysteine levels, it also showed a non-significant result. Among central retinal vein occlusion, branch retinal and macular RVO, the majority fall under the mild homocysteinemia. And when we compared the homocysteine levels in different types of retinal vein occlusions, the central retinal vein occlusion and branch retinal vein occlusion have shown significant results, and in total the retinal vein occlusion has shown significant result with the raised homocysteine levels. The present study indicates the elevated homocysteine levels were prevalent among patients with retinal vein occlusion, aligning with findings from other studies which have identified hyperhomocysteinemia as a notable risk factor. And patients with elevated homocysteine levels had significantly higher values in both CRVO and BRVO groups, which are consistent with previous studies, and which also identified elevated homocysteine as the strong risk factor for RVO. However, it did not show any statistically significant correlation between the elevated homocysteine levels, visual acuity and macular thickness. These are the studies. The conclusion is, it is found that retinal vein occlusion is commonly associated with raised homocysteine levels, but there is no association of elevated levels of homocysteine levels in visual acuity and central macular thickness at presentation. Thank you.
Homocysteine is, I don't know, it is thought to be a culprit. I think it's some sort of overrated culprit for any venous occlusion, be it BRV or CRV, what I think. And it's a very costly investigation, especially what we work at a government hospital level, unnecessarily we spend on it. Anyways, generally we go for homocysteine investigation in a young patient who is having BRV or CRV. First BRV. All your patients are above 18 years, elderly population. It's not a specifically young patient. You have taken elderly population also, one. And what second question is, what is the novelty of your study? It's a known fact. What is new about your study?
So in the other studies, they have not compared the elevated homocysteine levels, the effect of homocysteine levels on the visual acuity and the central macular thickness. So we have studied the correlation between visual acuity, elevated homocysteine levels with the visual acuity and the central macular thickness.
Just one quick question. When you say you have correlated homocysteine with vision, can you explain how, why will it cause a change? Homocysteine does not directly cause a change, right?
Yes, directly it is not causing, but we just wanted to know if the amount of homocysteine, it can lead to the severe retinal vein occlusion. So will it is it actually affecting the visual acuity or not? Like,
Okay, maybe you can go back, refer to the literature. Is homocysteine associated more with arterial occlusion or venous occlusion? Okay. So the other thing is there any difference in the kind of visual acuity that you had in patients, or is there any difference between the kind of vascular occlusions with homocysteine levels? I mean, you are having retinal, only branch vein.
क्वेश्चन है कि नॉर्मली ऐसा हाइपरटेंशन से हो रहा है CRV और एक पेशेंट इसको होमोसिस्टीन से हो रहा है, तो व्हाट इज द डिफरेंस इन द पिक्चर?
Was there any difference in the clinical?
क्लिनिकल
Yes, please.
My study I will be speaking on the topic serum vitamin D levels. Alternation patients with retinal
Just
vascular
bring the mic a little close.
introduction. Retinal vascular is a group of retinal diseases that can cause severe vision loss in patients in the middle age and elderly population, but no age group is immune to it. The retinal vascular closure includes disease of both retinal artery and vein such as CRAO, BRAO, CRVO, HCRVO and PRVO. The incidence of CRO is reported to be range from 1 to 8 per lakh population. BRO is total than 38 of the acute arterial occlusion. CRO accounts for around 0.4% and non-profuse CRVO is the one which demonstrates more than 10 area of retinal capillary non-perfusion on angiography. BRPO have incidence of 2.3. The ischemic BRPO is defined as on frozen angiography as area with greater than 5 disc diameter of non-perfusion. Now the main objective of my study was primary, it was to estimate serum vitamin D levels in patients with retinal vascular occlusion and compare it with age and sex matched healthy controls. Secondary aim was to determine whether there is a difference in serum vitamin D levels between ischemic and non-ischemic subtype of retinal vascular occlusion. With this, the purpose of the study was, actually there is no study available in the literature which has analyzed serum vitamin D levels in all type of vascular occlusion, including those with retinal arterial involvement. This knowledge gap, we formulated our study to analyze serum vitamin D levels in patients with all type of retinal vascular occlusion and compare whether there is a significant difference between serum vitamin D levels in ischemic and non-ischemic retinal vascular occlusions. A method was used. The serum vitamin D levels analysis of patient with retinal vascular occlusion who was reported over OPD was done and compared with age and sex matched healthy controls not having RBO disease from general population. All patients in study and control group was analyzed for fasting blood levels of vitamin D using the VIDAS. We have taken the following normal levels of serum vitamin D as more than 30 nanogram per ml. Levels in between 20 and 30 was taken as vitamin D insufficiency. Levels less than 20 was taken as deficiency. And the patient with RBO was categorized into ischemic if there is presence of neovascularization. The inclusion criteria of our study was all patients diagnosed with RBO with age more than 18 years. All cases of retinal vascular occlusion clinically diagnosed by our ophthalmic department at AIOCMT3 Pune. 50 patients with any observable occluded disease which was age and sex matched were included in the group. Total there were 50 RBO cases and 50 control cases. Our exclusion criteria was age of patient less than 18 years, patient with concurrent retinal diseases which were likely to present with capillary non-perfusion and neovascularization like diabetic retinopathy, retinal vasculitis and hypertensive retinopathy. Patient already on calcium and vitamin D supplements were excluded. Alcoholic cases, renal and hepatic disease were also excluded. This was the result in 50 cases of patients. There was 30 cases of CRPO, there were 30 cases of BRPO and there were 2 cases of BRPO respectively. In age and sex match there were 32 males and 18 was female in the patient group as compared to 33 in male and 77 in the control group. The mean age of our patient was 62 in the control group and 16 patient group. In patient group 36 had serum vitamin D deficiency out of which 20 were male and 11 were female. But there were no statistically different association found between sex and serum vitamin D levels. Serum vitamin D values in control and patient group. Here in the patient group we found a very less serum vitamin D level as compared to the control group. The difference in the mean vitamin D level between the two groups were found to be statistically significant. Vitamin D levels in RBO group, in the patient group, we have the less vitamin level as shown in the picture. There was in the patients, 72 patients have deficiency as compared to the control where we have the 20% of the cases. Among all 36 cases of vitamin D deficiency, there were 12 cases of CRPO, 18 of BRBO and 4 cases of CRO and 2 cases of BRO. On FFA, 70 cases in the patient group found to be ischemic. The difference in the baseline BCA between the two subgroups were found to be statistically significant. In ischemic case and non-ischemic vascular occlusion versus vitamin D, among 13 cases of CRPO, the ischemic cases have less vitamin D level as compared to the non-ischemic cases, subsequently in the other groups also. And the difference in the vitamin D level between the ischemic and non-ischemic subgroup were found to be statistically significant. This is a chart which clearly shows in ischemic cases, the vitamin D level is significantly low as compared to the non-ischemic cases. Though this was a limitation of my study, since it was a small sample size, it was a case control study which provides only one-time data frame, hence long-term effects can be elicited. It was a single center study. More centers need to be included in this study. Discussion, the mean serum vitamin D level in our patient group was found to be 18 as compared to the control group which found to be 32. This study was first time determining the vitamin D level in whole spectrum of retinal vascular occlusion, including arterial as well as venous. This was not done previously in the published literature. Conclusion, the significant vitamin D levels in various subtypes of vascular occlusion in comparison with age and sex match controls points towards a probable role of vitamin D deficiency in pathophysiology in all types of vascular occlusion. In addition to it, the serum vitamin D level was found to be more significantly lower in ischemic cases as compared to the non-ischemic cases. These cases need to be monitored more aggressively, and vitamin D supplement may be considered as a possible future medication decreasing the severity of the disease. Thank you, ma'am.
And you want to stress that vitamin D deficiency is associated with ischemia.
That's overall. The main.
That is why it is effective in all ischemic diseases,
Yes.
retinopathy,
Yes, sir.
when given all plethora of
Yes.
diseases.
But I have gone through the literature, the biggest study like Rotterdam study.
Why specifically about CRV? I think it is effective for all ischemic diseases. Anything specific about CRV?
So we have taken actually the cases of RVO. The main what I have gone through the literature of a big study like Rotterdam study, Oli et al. And Epstein et al. What they have done the study.
मेरे कहने का मतलब है ना कि हर इस्कीमिया में विटामिन डी की
Yes, sir.
यूजफुलनेस है।
Yes, sir.
आपकी स्टडी में भी you have shown that ischemic CRVO में it is more deficient.
Yes, sir. Statistically. Yes, sir.
I'm telling you, it's only specific for a CRV or it is unspecific, non-specific.
So
It's true for any ischemic retinal disease.
it's true for everyone.
Thank you.
Thank you, sir.
Next.
Good afternoon, respected panel. My study was comparison of choroidal thickness in preeclamptic, healthy pregnant and non-pregnant females by optical coherence tomography. So preeclampsia is a multifactorial multisystemic disorder occurring approximately 5 to 10% of pregnant women worldwide. It causes various organ dysfunctions including the visual system. High vascularity with poor autoregulatory mechanism makes our choroid particularly sensitive to hemodynamic alterations in preeclampsia. Thus, assessing this choroidal thickness may be used as a predictive marker in preeclampsia. So there were a very few prospective comparative studies in preeclamptic women, and there was a very lacuna in the literature. So the purpose of our study was to measure and compare choroidal thickness in preeclamptic patients, healthy pregnant women, and age-matched healthy non-pregnant women, and to evaluate any correlation between the subfoveal choroidal thickness, mean arterial pressure in the preeclamptic group. So we recruited 30 each in the 3 groups, 30 healthy pregnant, 30 preeclampsia, and 30 age-matched healthy non-pregnant controls. So total 90 subjects were taken. The study duration was 12 months. The inclusion criteria was women within age group of 20 to 40, less than 4 childbirths, best corrected visual acuity of 6/9 or better, and OCT images with a good signal strength of more than 7/10. And exclusion criteria was refractive error or IOP, which was not normal, any recent ocular history or systemic history. So after detailed ocular systemic obstetric history, we took detailed ocular examination and measurement of choroidal thickness by SDOCT in the EDI mode, enhanced depth imaging, and the measurement of mean arterial pressure. And lab investigations, urine protein was taken in preeclamptic patients. So in this image, there is a representative photograph of each group, A, B and C. So this was the subfoveal thickness, 1500 microns nasal and also 1500 microns temporal was taken manually and recorded. So A shows preeclamptic women, B is healthy pregnant and C is healthy non-pregnant age-matched control. So after the comparison of ocular, obstetric, systemic parameters and also of the choroidal thickness between the groups, which was taken as subfoveal, nasal, temporal and average in both the eyes, right and left. The summary was that there was no significant difference in terms of IOP, central corneal thickness and axial length between the 3 groups. That is, all the 3 groups were comparable. No significant difference in the gestational age, gravida status and estimated fetal weight between the healthy pregnant and the preeclamptic group as well. The significant difference between 3 groups was in the mean arterial pressure and the body mass index, because it was highest in the preeclampsia group. Healthy pregnant group has the highest choroidal thickness, followed by the healthy non-pregnant and the preeclampsia group in my study had the thinnest choroid. So this difference was statistically significant in all the three groups across the nasal, temporal, subfoveal average in both the eyes, except for the nasal choroidal thickness in the right eye. The correlation between the mean arterial pressure and the choroidal thickness was found to be inversely related. The correlation was statistically significant in all groups combined, but was insignificant for any single group separately, the mean arterial pressure. So our current study showed significantly less choroidal thickness in preeclamptic patients as compared to healthy pregnant and non-pregnant women, suggesting that increased choroidal vasospasm in preeclampsia. However, no significant correlation was found between the choroidal thickness and the mean arterial pressure. So this implicates that the choroidal thinning is governed by multifactorial choroidal vasospasm and endothelial dysfunction, systemic dysfunction, and not solely attributed to the mean arterial pressure. So these are the other studies, which are, none of the studies are from India. So there was a difference in the literature. In a few studies, there was a increase in choroidal thickness in preeclampsia, on the contrary to our studies. What was different here? They took severe preeclampsia groups, which had retinopathy changes. But in our study, we took preeclampsia without any retinopathy changes. So choroidal thickness can be used as a novel biomarker in preeclampsia patients as an adjunct to other parameters. And future prospective comparative studies should be taken at a larger scale for better understanding of choroidal changes in preeclampsia. Our study is also now published in the Indian Journal of Ophthalmology. Thank you. I would also like to add the limitations of my study. One was we did not have spectralis OCT. We had a spectral domain OCT, so we used the EDI mode. And also we did all the measurements manually using the caliper. And a future study with a larger group will be needed. Thank you so much.
It's a very good and interesting study. Just want to have a discussion of sort.
Yes.
We all know that in pre-eclampsia, actually the blood flow to all the parts of the body increases as compared to a normal pregnant. Is it so?
Sir, in healthy pregnant, according to the literature.
Vascularity किसमें बढ़ेगी? Pregnant, healthy pregnant में सर आप या pre-eclampsia?
Sir, in studies in healthy pregnant.
No, I'm talking theoretically.
Theoretically, sir.
Theoretically, in pre-eclampsia, the blood flow should increase.
No, sir. In preeclampsia, there is abnormal placentation. Because of this abnormal placentation, there is systemic vasospasm. So there is choroidal ischemia. Whether and in healthy pregnant, there is increase in blood flow. So this is in accordance to my results that in healthy pregnant, the choroidal thickness is increasing. And in preeclampsia, the choroidal thickness.
There are two things. One is the thickness of the choroid, and one is the flow of blood. What I want to just, I am also not very clear about it.
Yes.
But what I wanted to know if we can measure the choroidal vascular index.
Yes, sir. There are
by
studies.
octa.
Yes, sir.
To know the exact blood, does the blood flow also decreases or increases?
Yes, in studies and literature, it has been described that choroidal vascular index has also been described. It decreases because of systemic vasospasm. And as choroid is the most vascular organ of our eye part,
it is the best part to assess because
it
it's
is
the
the
most
best part
vascular.
for any systemic disease. So we wanted to correlate.
So just a curious question.
Yes.
How much prolonged vasospasm do you think should result into decrease in thickness? Because this is just for a transient period.
Yes.
Eclampsia is only transient.
Yes.
So actually what happens is all the ischemic changes, most of the ischemic changes in these patients is reversible. Within 6 weeks everything is gone. Isn't it?
Yes.
That also in sustained eclampsia, not pre-eclampsia.
Yes.
So why would there be? Because there is just focal vasospasm.
Ma'am, even in when I was recruiting subjects, so in some preeclamptic patients, there were also neurosensory detachments, which we excluded. So even in preeclampsia patients, acute vasospasm causes neurosensory detachments and retinopathy changes before developing eclampsia. In preeclampsia group itself, it is causing because of
here the line is very fine. We are talking about PIH or pre-eclampsia. only retraction. That is what I'm saying. Because this is a very fine line. PIH is a precursor to PH.
Retinal vessels have a quality of auto-regulation, which choroidal vessels do lack.
Yes, sir. This is exactly the point of my study, that choroid is having
Maybe in the
a
next
poor
attempt, if you can work
auto-regulatory
on
mechanism.
octa and choroidal vascular index, and
Yes.
probably the flow is the same.
Thank
But very fun. चले सर हाँ एक फोटो ले लो बेटा सर
Please.